Hi, everybody. Let me fix the lighting just a little bit. I'm not sure if that made any difference at all, but it's very nice to meet everybody. My name's Rachel, and I will be leading your class for today. This is the prenatal class. It goes over a little bit of everything. It's the Childbirth Masterclass. So I've been doing this for a while. For those of you who don't know me, I'm a maternity nurse. I'm also a certified lactation counselor, and I really enjoy doing these classes. It really kind of helps to bring everything into perspective. So to start out, this is an amazing class. The first part is going to be pregnancy, and then a little bit of childbirth. And then I also have a second part, which will be for newborn care and postpartum care. So to start off, we do have, this works as like a normal YouTube channel. It's just what we will be doing is after this video, I will be discontinuing all of the comments so that, for privacy and everything, because we will be asking questions and I want you guys to feel comfortable asking questions so that we can tailor your needs for every individual person. I do like to have this more of a Q&A. That way also everybody feels comfortable asking questions and it can be personal to what you guys need. So to start off, you can use the chat box and just write your name, where you're from, and if you have any specific questions or goals for this class. That will really help to kind of gauge where we're at and what we would need to talk about a little bit more. So to start off, I am Rachel from Florida. So I just made the first message there. And then I look forward to meeting more of you guys and learning all about you. And if you haven't, also, I have a website, mommydidyouknow.com, that has a lot of great information. And then if you're on the online event page, all you have to do is open the YouTube video, and then you can open it from the YouTube section, and then you'll be able to comment and everything too. So for this part, we're going to talk about pregnancy. So all of you guys should have the PowerPoint, but I also have it on the online event page from Eventbrite, and it's also in the comment section of this video as well. So to start off, there's a lot of different changes that you'll be expecting during pregnancy. The first trimester, and then we have New York City, we have Washington State, and we have someone else from Florida. That's fantastic. So very excited to meet all of you guys. And then I really hope that you guys learn a lot and that it really meets all of your needs. So in the first trimester, I'm sure you guys have noticed, you'll have the frequent urination, the morning sickness. For me, I had a lot of morning sickness, but especially with my first baby, I remember I was working in the hospital and I worked night shift at the time. And then in the morning, I would actually get so sick that I would have to be sucking on a lemon as I was giving a report to the next shift. So it could get pretty bad. What helped me was ginger tea actually helped me a lot. And what I would do also is I would take a ginger ale, put it in the microwave for like a minute, and then I would put a tea bag inside, and then that's ginger tea. And that actually helped me a lot, in addition to kind of staying away from too acidic foods, although the only thing that helped me sometimes was lemons. But you kind of just gauge your body, and see what's going on with your body. Then the frequent urination, that was one thing I didn't realize with my first pregnancy, is that you actually pee a lot in the beginning of your pregnancy. For some reason, I always thought that it would be in the end as the baby gets bigger and puts more pressure on your bladder. But especially in the beginning of your pregnancy, you're going to be having a lot of circulation that needs to go through. And there's a lot of changes going on in your body. And a lot of times, the urination is not only from the pressure on the bladder, but it's also from that increased fluid from the baby, from you, from all the changes going on. Heartburn. Unfortunately, some people deal with that for the duration of their pregnancy. What really helps is staying away from acidic foods, especially sometimes when you're sitting up, it really helps. So if let's say you're going to eat, try not to eat too late, because that will definitely cause your heartburn to be worse. Second trimester, you start getting kind of this all of a sudden this burst of energy. And sometimes it kind of feels like it's coming out of nowhere, where you all of a sudden get this energy. You'll also start having a growing belly. Your breast will start getting a lot more tender, although that could also happen in your first trimester as well. You'll start also getting your linea nigra, which is this dark line that comes from your navel region and goes all the way down to your pelvic region. And then that goes away on its own. You don't really have to do anything for that. Some people do get nasal congestion. Just make sure that you're not using Afrin nasal sprays, because Afrin nasal sprays, actually, they can cause you to have heart abnormalities as well. And then third trimester, the biggest is, you just feel like you want to get this baby out. And I know most people, when they're starting my classes, they're usually in the second or the third trimester. So I want to ask you guys, because like I said, this is more of a Q&A. I want to hear from you all. How many weeks pregnant are you? Or you can say which trimester you're in is fine. And if you are dealing with anything specifically, I would really love to help you guys out. Make sure that if you guys are dealing with something, that I can be a support for you guys. And if you don't want to say it in public and you do have any questions for me, you can also send me an email at mommydidyouknow@gmail.com, and I would be more than happy to help you out. And then I'll give you guys a minute so that you guys can all answer that. And then in the end of my class today, I will actually, 34 weeks, congratulations. So see, most people are about in their second or third trimester. So in the end of this class, I will also be giving out a free consultation with me, which is fantastic. It really is a help, not only for breastfeeding, but also for childbirth planning, pregnancy, for baby care. I also work in the nursery a lot. I work in the NICU. So I can definitely give you a lot of great tips. And actually, I breastfed my kids, both of them, for about a year. So 33 weeks. Had a pretty fabulous pregnancy. Restroom through the night. Sleeping is limited. You are just like a lot of people, especially as you get closer to the childbirth. Wow, so it looks like everybody is about 30 to 34 weeks. Congratulations. So the light is in the end of the tunnel. Your baby's almost going to be here. So I'm so excited for all of you guys. So it seems like insomnia is a big issue sometimes. What can help, number one, is trying to get rid of electronics before you go to bed, just because sometimes, especially moms in general, we think a lot. And then before we go to bed, you're on your phone, you're looking up baby things, and you're looking up delivery information and childbirth information. Of course, you're probably taking my class too, so you're probably looking at all of those lessons, but try to, if you can, stay away from technology as much as possible. I'm sorry about that. And then when you are sleeping, try to pee, even if you don't feel like you really have to. Before you go to sleep, try to pee, just to kind of keep it as empty as possible, and try not to drink fluids before you deliver also. And then one thing that I noticed is, you shouldn't really be sleeping on your back anyways when you're, especially 30 weeks and above. You shouldn't be even before that, but definitely all of you guys are around 30 weeks and above. You guys should not be sleeping on your back, but sometimes sleeping on your back makes you want to pee more often, is one thing that I noticed too. But when you're on your side, you'll be more comfortable. And what helps too is if you put a pillow underneath. And what I notice is if you just take a flat pillow and put it between your legs, it doesn't really do much. But if you fold the pillow, it usually helps a lot more, because it helps your hips that they're not so close and kind of entwined like that. So if you fold the pillow, put it in between your legs, it'll probably help you a lot. And you can also use lavender, essential oils, and aromatherapy, things like that. So back pain. So Helena has back pain. I had a lot of back pain, and especially mine got into sciatica, which is something else that you definitely don't want to get a part of. But sciatica basically feels like a lightning coming from basically your back and all the way down. And I would actually get that a lot when I was with my patients, and I'll be checking them as a postpartum nurse. I have to check your uterus a lot. It's called a fundus. And I would be checking their uterus, and I would bend down. And as I was pregnant, I would all of a sudden get sharp pains that I wouldn't even really be able to stand up again. So I am with you there. With back pain, what helped me a lot was getting a support band. They have them very cheap on Amazon. And then I also have a few on my website on mommydidyouknow.com. You go to the maternity section, and then you go to the maternity accessories. I have a cheap one that's like $16 or something like that. And then I have one that has like 5 different, parts, just because I know that back pain really can, let's just say it's uncomfortable. So really that back support helps a lot. Make sure that it's supported from, depending on the severity of your back pain, making sure that you're supported from different angles. They have one that's just kind of like a little band. Then they have another one that kind of comes from a whole bunch of different angles. So that will definitely help you. And then 35 weeks just got put on bed rest for preeclampsia. So Ashley, I'm so sorry that you are going through that. Preeclampsia, for those who don't know, is high blood pressure. And there are a few reasons why you're nervous about high blood pressure. One is because if you think about it, let's say you have high blood pressure and your blood vessels are constricted from all that blood pressure. What happens is the baby will not be getting as much nourishment because your blood vessels are constricting. Therefore, the blood flow to the baby is restricted. So you can end up having a baby that has low birth weight because they're not getting the nutrients that they need, as well as sometimes there can be birth complications or preterm labor, as well as sometimes they might want to deliver you earlier. So Ashley, depending on the severity of your preeclampsia, normally they would want to induce you or possibly have the cesarean around 39 weeks. However, with preeclampsia, usually they'll do it around 37, unless it is very, very severe. By the fact that you're on bed rest and not in the hospital, that tells me they're probably scheduling you for about 37 weeks. But depending on the severity, sometimes it can be sooner, but you definitely want to keep track of your blood pressure. And then I normally recommend to try to check your blood pressure levels before you take any medications for it. Just because, let's say you might actually have a time where your blood pressure is not as high as you might think, and then you end up taking this labetalol or Procardia. Procardia has a way of dropping that blood pressure really fast. So I would always check your blood pressure before you take medications. I don't know how many times I've seen that blood pressure was kind of borderline or high, then Procardia comes and boom, it goes down really fast. So make sure that you're keeping track of those. Then if you don't feel well, keep tabs on your body. Make sure that you're listening to your body and you're taking steps as necessary. So this was great. I'm so happy that all of you guys had a few questions and comments, because that's what we're here for. We're here to work with each other, to support each other. So my next section is your baby and just some different milestones for your baby. So who can tell me when your baby is considered early term? And you guys can look at my PowerPoint, don't worry. I have a little bit of a cough, but I'm still doing this class because I love you guys so much. But who can tell me when a baby is considered early term? Before this early term stage, usually babies, so actually 35 weeks is definitely too early. What you're thinking of, Helena, is probably before 35 weeks, it's an automatic admission to the NICU. They're between 35 and 37, they're still preterm. 37 weeks is when they're considered early term. And then 39 weeks is when they're considered fully term. So what does that mean for you guys? Elective inductions and cesarean births are usually scheduled around 39 weeks. So let's say you're a repeat cesarean birth, or let's say you need to be induced for whatever reason, they will normally do it at 39 weeks, unless there's complications, such as we have Ashley who has preeclampsia. Then in that point, they would probably schedule you a little bit earlier when your baby is early term, if that makes sense, just because they want to try to have the baby, that bun in the oven as much as they can. So before 35 weeks, your baby, if you were to deliver for whatever reason before 35 weeks, that's normally an automatic admission to the NICU. And I work in the NICU sometimes too. So kind of a jack of all trades. I work NICU, a little labor and delivery, but if I work labor and delivery, I take care of pregnant women. I don't really do the actual childbirth part. I might have, like, let's say if one of you guys was in the hospital and you had to be there for observation, you had hyperemesis, you had high blood pressure, or your blood sugar was out of control, I would be helping with that. Or I do postpartum, which is after you have your baby, you have another nurse that takes care of you and the baby. I'm mostly postpartum, which is kind of my joy because it has a lot of instructions, a lot of teaching. So it's kind of interesting to learn about the different nurses. So I actually do a little bit of everything. So yes, between 35 and 37, you're still premature, but it is kind of late premature. So at least sometimes 35 and 37 weeks, as long as they're breathing okay and they're feeding okay, they'll usually be able to stay with you. It's just if they're not breathing okay and they're not feeding okay, and then they might have to be in the NICU just for a little observation. But it all goes with the baby, just because every baby is different, every childbirth experience is different, and every mom is different as well. If you were to have a preterm baby for whatever reason, just make sure that you keep that baby warm, do skin to skin as much as possible, feed that baby frequently and effectively, but try not to overwork that baby with very long feeding times. That's one of the biggest things that I see for preterm babies that I've noticed as a nurse is that sometimes a premature baby will need a little bit more time to feed. So then you'll try to, let's say you're breastfeeding and you'll try to breastfeed them for a long amount of time, and then they kind of poop out on you, and then they don't have as much energy to continue feedings, or their sugar drops really fast. So if you have a preterm baby and you're breastfeeding, try not to let that feeding session go more than about 20 minutes without a nice rest in between, because sometimes babies can take up to an hour to feed. But if you have a preterm baby that doesn't have as much brown fat, or even let's say you have a small baby that doesn't have as much brown fat, if they're breastfeeding for a long amount of time, you can definitely wipe them out, and then they won't have enough energy to continue, because especially those first few days, there's a lot going on. So don't keep, if you have a small baby or premature baby, too long, and make sure that the baby's feeding effectively too. Then we have your typical prenatal visit schedule. So out of curiosity, I want to see how many of you guys are paying attention to your labs. So if you guys can comment with a few labs that you've seen them draw in your prenatal visits. So in your OB's office, what labs have they done for you? What labs have they drawn for you? And you don't have to be too specific or anything. I just want to see what you guys remember, because as patients, especially as a pregnant mom, sometimes we just kind of give our arm out, and we're like, all right, just do whatever you need to do. Sometimes you're just like, do whatever you need to do, take whatever labs, and then you don't really remember the labs that they've drawn, or you don't really pay attention to what those results might mean. But it's important to know what they're drawing, what they're taking, and what would that mean for you in results of those when you're talking about the results. For example, if something was positive, what would that mean for you and the baby? If something was negative, is that a good thing? Is that a bad thing? Different things like that. So to answer, sometimes I know that the comment section sometimes is a little delayed. So sometimes people, CBC, BMP, glucose. Oh man, you know yours. I'm so excited. Yeah, actually, you're on top of it. Well, you probably know more too, because preeclampsia workup, a PIH workup. A PIH is pregnancy-induced hypertension, is usually a lot more lab work than you would have if you did not have PIH. So you probably have been stuck more than all of us combined. So I applaud you for all the work that you are putting in. CBC is a complete blood count, guys. What that is mostly, we're looking for our hemoglobin, our iron levels. We're looking, now all the labs are coming in. We're looking for our iron levels, see if you're anemic. If you're anemic, they might give you IV iron. They might give you blood before you deliver. It's mostly to see a baseline, to see what'll happen. And I don't know if I'm saying this correctly, Sebastiani. I probably said it correctly. I think maybe I did. Glucose test, which you failed. Sometimes you might fail the first one and then you'll pass the next one because sometimes they do repeat it. But we will be talking about gestational diabetes as well towards the end of this. And I have a whole spiel about it because I think gestational diabetes is so important to understand. And if you guys do have any questions about it as we're going over that section, definitely let me know. And then Ashley also mentioned BMP, glucose, blood type. So the biggest things that we're looking for in the CBC, we're looking to see what's your white blood count. We're making sure if your white blood count is high, sometimes that can be an indicator of infection. Your white blood count is kind of like your soldiers of the body. If your white blood cells are high, they're at high levels, sometimes that can say that the soldiers are gearing up for battle. Let's kind of see what's going on. Then our iron levels, hemoglobin, hematocrit, that's telling us if you're anemic, if your hematocrit is low, that might give us an indication to see that baseline. And then your platelets are your clotting factors. So if your platelet level is low, that can be a concern because let's say you were to have bleeding or if you were to have a cesarean birth and your platelets were low, then you can be at risk for bleeding. Because your platelets kind of all clump together to stop that bleeding. So that's what we're looking for. Your blood type and RH factor, that's also important. O is the universal donor. AB is the universal receiver. So we're checking your blood work. If you are also a different blood type than your baby, we might have to do extra blood work on the baby because that goes into Coombs, which we go over also in my Childbirth Masterclass on the online, which I actually have a 26, I actually just created it this week, but I went a little overzealous because I'm like, there's so much information out there. So I made a 26-day series called the Childbirth Masterclass online. And when you go to mommydidyouknow.com, you'll actually be able to see it. But it has information about Coombs positive babies and blood works and all of that good stuff, just because there's so much information out there. And I will be sending it as an email as well, just because it has some really great stuff. So if you are a negative blood type, I'm not sure if maybe a few of you are negative, but you will need something called RhoGAM. Basically, if you think about it this way, let's say you are O negative, you do not have those specific antibodies, they're your O negative. And let's say your baby was positive, O positive, B positive, it doesn't matter the blood type, but if the baby was positive, you would be developing antibodies. So then if you have another delivery and you have those antibodies already in your system, you can actually end up miscarrying your next baby. So what RhoGAM does is it stops the creation of those antibodies. So therefore, let's say you're O negative, you would be having RhoGAM during your pregnancy, and then they would be doing a blood type on the baby. And then if the baby is positive, then you would have RhoGAM after your delivery as well. And that RhoGAM is to protect your next baby and also to kind of prevent creation of these antibodies that can mess up your blood, that actually might even get in the way of blood transfusions in the future. That actually, if you don't have RhoGAM and you get sensitized and your blood starts getting that mixture with the O negative and whatever positive, you can start having issues with that. So that is RhoGAM. And then we did have a little bit about, they did blood work, ton of information, blood type, gestational diabetes. So a lot of people do end up failing the glucose test. So what that means for you guys, a lot of the time, I would say the majority of the patients that have gestational diabetes are controlled by diet. Diet means that you'll take away sugar as much as possible. You'll try to drink a lot of water, stay away from sugars, from carbohydrates, and things like that. And then, did we have any questions about any of the results or exams? Because if you did have any questions about it, you can always just let me know. So then we have some typical exams here that it's also, if you look on the PowerPoint, we are slide number 9, just in case you got messed up or mixed up on where we were at. So my next section that I want to go over is actually prenatal complications, which is good because the two big ones that we were talking about before was preeclampsia and gestational diabetes. So we did mention a little bit about preeclampsia. I want to mention a little bit about gestational diabetes and what that means for you guys and what that means for your baby. So babies that have moms that have gestational diabetes, they have a few kind of things that you would want to look out for. One is sometimes they are larger for gestational age. So let's say you have 39 weeks, and normally, let's say a baby might be 7 pounds, but that's when you hear those babies that are like 10 pounds or 9 pounds. Usually, although not always, they're from gestational diabetes. So Richard was saying high-risk deliveries. I actually do have experience with quite a few high-risk deliveries, mostly during the pregnancy part, or I would help out. No, you're fine. Or I would help out in the NICU. Do you have any specific high-risk deliveries that you were talking about? Usually what I'll deal with is like preeclampsia, preterm labor, gestational diabetes, things like that. But usually with high risk for gestational diabetes, the biggest thing is that you'll have a big baby. And also, if you think about it, your placenta is giving them a lot of glucose, so that when the baby's out of the body and they're not having that supply of glucose, sometimes their glucose levels can plummet down. So the biggest complications with baby is that number one, you'll have a big baby. And number two, sometimes those sugar levels really can drop really quickly after you deliver. So what can you do for your baby? The biggest thing is try to feed as soon as possible. So within the first hour of life, if you are breastfeeding, you can always make sure that you have an effective latch. Make sure that your baby has a nice wide open latch. And I do discuss latching more on on the baby and postpartum side of this course. But also, if you look on YouTube, I have a whole bunch of breastfeeding videos. And I do also have consultations, private consultations that we can talk one-on-one, either by phone or video. And I usually recommend to have it during your pregnancy. So if you go to mommydidyouknow.com and consults, that consults tab actually has a booking portal that you can actually directly schedule an appointment with me so that we can talk one-on-one. And right now my sessions are very affordable. It's only $25 for a session by virtual visit. And then if you're in the Palm Beach, Broward, or Martin counties, I do also do home visits. So that's another thing to think about. And all of those are scheduled by the portal. So then for preeclampsia, high blood pressure, we did talk about early delivery, medications. Definitely with preeclampsia and gestational diabetes, it's a lot of lifestyle changes that you can do, and then also medications. For gestational diabetes, they have long-acting medications that, let's say sometimes it's like a pill that you can take that will last for the rest of the day. And they also have coverage of insulin, which is, the insulin that you always hear about. Those are short acting, in case you're wondering what's the difference between like a pill that I would take that's a long lasting, and why do I would have to take a pill and insulin? Usually the insulin is a short acting coverage for your meal, while the pill is usually long acting. And then very similarly, actually preeclampsia, the blood pressure issues, they also have long-lasting and short-term medications as well. Labetalol is usually a short-term medication, and then Procardia is usually the long medication. So that's something where you would take, let's say, a Procardia daily, let's say at 9 a.m. or something like that. That would hopefully last you for the rest of the day. And then you can have, let's say, a labetalol maybe 3 times a day, because those are short acting. So those are the difference, in case you're wondering. All right, so we finished our pregnancy and pregnancy complications part. Now I wanted to spend the next half an hour about childbirth. That's usually the part that most people want to hear about. So I wanted to know, does anyone have any questions about the pregnancy part? And then to answer more of Richard's question about the high-risk deliveries, usually if you have a high risk, just to add a few more things, if you have a high risk pregnancy, make sure you're usually seen by a perinatalogist as well. Make sure that you're following up with your perinatalogist visits, that you're keeping aware and that you're an active participant in your medical care. And then another thing that sometimes they don't really tell you, but if you are a high risk delivery, you want to make sure that you have a critical care unit that is good for your newborn. So look up the NICU. That's something that sometimes they might talk to you about, sometimes they don't, but you want to look up in the hospital that you're going to. If you have a high-risk pregnancy, what is the NICU level? Is it a NICU level 3? If you have a high-risk delivery, I would recommend going to a level 3 or higher, just because they can deal with whatever comes your way. And with a newborn baby, you never know what's going to happen. And if you're at high risk, you want to make sure that you have the medical staff and care that's necessary for your baby in those first crucial minutes of life. So high-risk deliveries, make sure that you have a good NICU, good OB, and try to see what would the scenarios be included in your medical care, be included in your decisions, and you can go from there. I really hope you guys are learning. And then, like I said, if you guys have any questions, you can always let me know, and you can always email me too, because I know that sometimes people don't really, they don't really like to comment that much, or they don't like to be that interactive, but that's completely understandable. You can always call me or you can email me as well. And my contact information is on the event page, and it's also on my website. So our next section over here is preparing for childbirth. Childbirth planning is one of my specialties. So definitely, if you wanted to plan for your childbirth, you can always contact me for a consultation. So the first part we're going to talk about is the checklist for the hospital bag. So most of you guys are probably in the stages of planning your hospital bag. I'll usually recommend to have it ready by 36 weeks, possibly earlier if you have, like a few people did have a history of complications of gestational diabetes and preeclampsia. I would probably have that hospital bag earlier just in case. But a few things you don't really need to bring unless you really want to. Number one is diapers and wipes. Usually they have them at the hospital, but but you can also use your own if you wanted. So let's say you're at the hospital and they use Pampers, but you want Huggies, you can always bring Huggies. Or let's say you want organic wipes and your hospital uses Pampers wipes or something like that. You can always bring your own, so that's fine. But they do provide you with stuff. And me, for one, I would prefer to have the stuff provided, especially that first few days. It's kind of like a blur, so at least the hospital does provide that. And then another thing, especially if you have a cesarean birth, is an abdominal binder, abdominal support that we were talking about earlier. They usually do provide them in the hospital. It's just sometimes you have to ask for them. But every hospital that I've visited or I'm so sorry about the cough, or trained at, they've always had abdominal binders, support bands. The only thing, sometimes I had to get a doctor's order to have it open for me as a supply. So sometimes you can always talk to your OB and say, hey, can I have an order for an abdominal binder? And then usually what that helps with, let's say you have a cesarean birth and you have an incision going across your belly and you're trying to take care of a newborn baby. It can be painful, especially that first few days, because it's a surgical incision and you had surgery. So the support band helps to kind of keep pressure on that incision. So it's not for the belly, really. It's for your incision. It's for incisional support. But of course, it helps everything. So that helps to keep you walking. Because me, for one, especially as a nurse, I want to make sure that my patients are walking, that they're staying active. The last thing you want to do is stay in the bed all day. And that's also cesarean births as well as vaginal deliveries. You do not want to stay in the bed all day. You want to be up. You want to be And then a few things that you can bring, and some of these things are actually kind of stuff that I've noticed as a nurse, as a postpartum nurse especially. Number one is documents. A lot of people actually forget their documents, but especially your prenatal records. I always tell the patients when I see them or I'm giving consultations, try to bring your prenatal records, especially because if we do not have certain records or we don't have certain labs, we would have to work you guys up again as if you're starting from square one, because let's say you were going to deliver and we didn't have those results. We would have to have unnecessary treatments on the baby and unnecessary treatments on you. So you would definitely want to keep your prenatal documents in hand, or even some doctor's offices have the portal where you can open it up and get your lab work. So I would say if you're beyond 32 weeks or 36 weeks, I definitely, when you go to the doctor's office, ask them for your lab work. Even if you don't have like the full, I know some prenatal records, doctor's offices have it like this big. Even if you have just your basic lab work, what's your HIV status, what's your GBS status, what's your hepatitis B status, all of those things can save you labs. So even if you have those basic statuses, it will really help you out, because what happens is, let's say we don't know your GBS status. This is just getting as just an example. GBS is group beta strep. They normally do this around 36 weeks, sometimes a little earlier. So GBS is a naturally occurring bacteria that's in the vaginal area. So if for an adult, it's fine, but if a baby has, it can actually cause infection. So if you were GBS positive, we would actually be giving you antibiotics before you delivered. And then if you did not have at least 2 doses of this antibiotic, then the baby will actually have a whole setup of infection screenings to make sure the baby does not have an infection. And the same thing is if you had a long rupture time. So what that means for you guys is, let's say we don't know your GBS status, we would treat you as if you were positive. So then therefore, let's say you were negative, but we didn't have your results, you would still get those antibiotics and your baby might have those unnecessary lab results. And unfortunately, infection screenings are venous sticks. So it's like a butterfly or an IV needle that they would use, rather than if you, let's say you didn't have to do that infection screening, usually the only blood tests we do are heel sticks. And it looks very similar to the lancet that they would use for your sugar levels, that they just kind of pinch your finger. It looks very similar to that. However, if we had to do an infection screening, that one, a blood culture has to be done by venous stick. So that's a little bit more invasive. So I usually say bring your prenatal records or at least your lab results so that you can hopefully avoid those. And then try to bring some money as well, or at least cards, just because if you think about it, the hospital's not, some of them might be open 24/7, but some of them might not. And then what ends up happening is, let's say you are hungry and it's 8 o'clock at night, at least you have some money, maybe you can get Uber or Lyft. And, actually Uber Eats, most hospitals will, even now with the quarantine or pandemic stuff going on, at least in our hospital, we do accept food from the outside. It's just the visitors cannot leave the hospital. So you would have to meet with them in the main entrance. And then some people order Uber Eats, or some people have family members bring them food. That's usually what we do. And a lot of times also hospitals have vending machines. So at least having those really do help. For mom, just think comfy, think comfort, try to bring fuzzy socks, fuzzy slippers, comfortable gowns, comfortable robes as well. Stuff that you can easily breastfeed in is fantastic as well. Bring your toiletries. They do provide toiletries, but honestly, sometimes it's not the best, and you want to feel like a spa, basically, after you have the baby. That first shower is so important. It makes you feel like a new person. So you want to make sure that you have the toiletries that you like, if the scents that you like, those smells that you like, sometimes those perfumes, as long as it's not too strong, because of course with a newborn baby, you don't want to have all these perfumes around. So for mom, it's all comfort. What you want to bring is stuff to make you feel like you're at home, comfortable blankets, comfortable pillows. For the baby, usually the hospital does provide the blankets, but you can bring your own if you want. And they do provide clothes. However, honestly, in all the hospitals that I've trained at and all the hospitals that I've worked at, the clothes are not that great. It is better if you bring your own clothes. The first few days anyways, you can do skin to skin as much as you can, but if you want to dress up the baby, it's better to bring your own clothes, just because sometimes hospitals only have the shirt, they don't have the pants. And then by bringing your own clothes, at least that really helps to kind of make you feel more at home as well. Your support person, think your support person is supposed to be supporting you. So you would want them to bring entertainment. Actually, I've seen some people, which is actually a really cool idea, they bring Amazon Fire Sticks, which is actually a really cool idea. Or, you can bring your laptop, you can bring your iPad. Sometimes, though, the streaming is not that great in hospitals, but I've noticed that on the Amazon Fire Stick, it's actually better than streaming directly on your laptop, which is actually a pretty cool little tip that I've noticed. Oh, and then another really cool tip also that I've noticed is that what can really help you is actually a long charger, because you would want a charger that, because let's say you're in the bed and you have the charger way back over there, and you just had a baby, or let's say you have an epidural, it's kind of hard to get up and go to the charger or go to the phone. But if you have an extra long cable, at least you can have a cable that's long enough that you can be in the bed comfortably. So that's another really cool trick. So now we're going to go on to what you would expect when you get to the hospital. So if I can have you guys ask me pretty much any questions that you have about the childbirth experience. So this can be about what to expect when you get to the hospital, what labs should I expect, any questions you have about vaginal exams, any questions about epidurals, because I really want to tailor to what you guys need. Because honestly, you guys can read these PowerPoints at home, but what is really important is to understand what you guys need as individuals. So if you guys have any questions about labor, childbirth, anything with planning, you can write it down and I'll try to answer it to the best of my ability. And then any questions that you guys have. But in the meantime, I know that it's a little delayed, the comments, but when you come in, you'll be signing your consent forms. You'll probably be signing your consent for blood products. So for epidurals, when is the appropriate time to ask for the epidurals? I completed pre-registration this morning, and she said it'll take 45 minutes to get it. Can you get it too early? So with my first, the best way I can explain this is with my personal experience. So with my first, I was kind of nervous about it. Usually the hospital gives you tux pads, by the way. So at least that was an easy question. It's just sometimes you have to ask them for the tux pads, but those are really nice. So to complete with the epidural, because I'm sure a lot of people have this question. With my first, I was a little nervous to have an epidural. So I kind of waited a lot. And what I noticed is that my labor actually didn't really progress until I calmed down and had that epidural. With my second, I pretty much told my doctor, if I'm in active labor, go ahead and put the epidural. So for me, I had it with my second when I was 4 centimeters dilated and in active labor, and my contractions were, I think they were about 4 minutes apart, 4 to 5 minutes apart. So my labor was progressing rather quickly. What you want for your contractions is about 3 to 5 minutes apart. And in what you'll see is if you're contracting too fast, so let's say you have a lot of Pitocin, which might have, if you are induced, you might have to have Pitocin. That can cause you to have a lot more pain in your childbirth. And just because that Pitocin causes you to contract. And what you'll see sometimes is something called tachysystole, which is where your contractions are coming too fast, too rapid, sometimes even 2 minutes apart. And then that is just as bad as if you are not contracting at all. So for you can be an active member of your medical team. And notice if your contractions are too close together, tell them, say, hey, my contractions are too close together. I don't think that they're supposed to be this close together. If you see that they're every 1 to 2 minutes apart, But you would want to check to see, and what you'll see with that also is everybody's different. And some hospitals, I know that they have the walking epidurals, and some hospitals have the one where you have to be on bed rest. I don't really know that much about the walking one because all the hospitals I've worked in always had the bed rest epidural. But the way that the bed rest epidural works is they'll normally, you'll be sitting kind of to the side of the chair. You'll have someone in front of you supporting you, and then you'll have the anesthesiologist behind you, possibly an assistant as well. They would put a drape over your back that has a little circle where your epidural is going to go. They would then clean all around it, the same cleaning supplies that they would use if you were to have surgery or have a cesarean. It's the same thing. And then they would insert the needle, and then once the needle is in and it goes into the epidural space, they retract the needle so that needle does not stay in your body, and the only thing that stays is the catheter. Through that catheter going through the epidural space, that is what they're administering the medication through. So I would normally say wait until you are in active labor, but you don't want to wait too long. And then especially if it is, let's say it's your third baby or fourth baby, you can kind of gauge where your body's at. So if you feel that you might not have time for it, definitely ask for it early on. The biggest reason why it takes a lot of time to have the epidural is because you have to have a liter of fluid first, or at least a bolus of fluid is what we call it, where we kind of pump you up with fluids. Because what happens with an epidural, one of the biggest side effects is your blood pressure goes down. So they would want to give you bolus of fluids first to kind of give you some cushion so that when you do have that epidural, that your blood pressure doesn't plummet down. So that's the biggest reason why they make you wait a little bit. I hope that answered most of your questions anyways. Oh, and then with the bed rest epidural, you would have to have Folian, which is normally taken out right before you deliver. And then you would take about an hour and a half or so to get feeling back to your legs, sometimes longer, and then you'll be able to pee on your own after that. And then for Rosa, I'll be getting induced at 37 weeks. Remind me ICP. I know it's probably a super easy acronym that I am forgetting completely. What should I expect when I get there? But normally with inductions, while I'm waiting for you to tell me what that acronym is, and I'm sure it's something so easy, is normally for inductions, you would get in, you'll sign your papers, they'll confirm your papers. You would normally get, even though you had a cholestasis in pregnancy. Yes, having to do with, see, I told you it was a simple acronym. Yeah, I actually see that a lot as well. With cholestasis in pregnancy, they would probably do some liver enzymes as well as the normal blood test. Either way, whether you were getting induced for cholestasis or anything else, you would normally have a CBC and a blood type and screen. So CBC, blood type and screen, just to get a baseline. If you had, let's say, preeclampsia, you were coming in for preeclampsia, they would probably do PIH labs again. That would be urine that they would do in addition to a BMP and possibly a few other things as well. For cholestasis, they would be doing your liver enzymes as well. They'll possibly be doing a metabolic panel, the BMP, the basic metabolic panel as well. So the biggest difference with that is your induction will pretty much be the same. It's just that you will probably have a little bit more vials, because normally a CBC would just be like a pink or purple top and your blood type and screen as well. But if you have cholestasis and they need to do liver enzymes, that's usually in like a yellow top or sometimes a green top, depending on the hospital. So it's just a different blood test as well. And then Richard for type 1 diabetes, and I'm not sure if it's Richard or maybe both of you guys are watching too, but for type 1 diabetes, they'll be doing sugar checks when you come in just to see your baseline, see what you're doing, and you will probably be on AccuChecks every 2 hours, usually while you are in labor. And then usually they won't really be feeding you while you're in labor. And then depending on if you need insulin after you deliver, they might have to do a few more sugars as well. when you come in for your induction, for whatever reason, depending on your vaginal exam, that will depend on how long your induction will take. So let's say they do a vaginal exam and your cervix is already soft and you're already starting to dilate and your body's already starting to get ready. Sometimes all you need is a little push of the Pitocin and that's it. Let's say you go in and your body's not ready. Let's say your cervix is still firm. Let's say you have not started dilating yet and your body's not really ready yet. They might give you a cervical ripener, which just softens the cervix. The difference is that the cervical ripener would have to be in your system. Usually it's a vaginal insertion for the cervical ripener, just because it has to ripen the cervix, which is in that area. Usually that's overnight. So So when you go for your doctor's office, they'll probably check you before admitting you to the hospital to see if you would have to have the cervical in place. So let's say your doctor says, okay, I want you to be here to be induced at 7 p.m., which is an awful time. It's change of shift, but doctors sometimes choose those times. So let's say they're like, I want you to come into the hospital at 7 o'clock. The nurses are changing shifts and you will have a cervical ripener overnight. Normally, you would have that cervical ripener for about 8 hours. So let's say you're in at 7 o'clock, they do your labs, they might give you some fluids, they might get an IV started, and then they'll insert the cervical ripener for about 8 hours and they'll be tracking your progress. They may or may not give you Pitocin during that cervical ripening. And sometimes if you're lucky, it actually causes you to start natural contractions as well. So that's the biggest difference, is just the cervical ripening if you're not ready versus the Pitocin if you already started and you just need a little bit of a push. For your vaginal exams, they'll be checking you pretty frequently, except the biggest thing is that if you have ruptured already. So let's say you came in and your membranes have ruptured. They try not to do too many vaginal exams if you're already ruptured, just because if, let's say, that bag of waters that is protecting the babies around the baby, and then we're coming in with this hand that we tried to be sterile, but at the same time, you know, there couldn't be bacteria or anything. And every time we enter and the bag of waters is not protecting the baby, that's an increased risk of infection. So that's why, especially for, let's say you have preterm labor and you've already broke your waters, usually they won't really do vaginal exams that often. And then the biggest thing that they're checking, and you can see this from the PowerPoint as well, but they're checking position, they're checking to see if the cervical's right, they're seeing what your dilation is. And then of course, if your position is different as well, that will definitely play a role in how they will be delivering the baby. Let's say the baby is breech and the baby's feet first, and then you might have to have a cesarean birth, or sometimes they might have to manually change the baby as well, which honestly is very difficult. They're also looking at the position of the cervix. The position moves from posterior to anterior as you progress through the labor. So they're just checking on that as well. Then we have different stages of your labor. So let's say you were induced, you're admitted, you have your nurse who is absolutely fantastic, of course, especially if, she's me. And then you're progressing through your labor. The pushing is stage 2. So the stage 1 for labor, there's actually different stages. Stage 1 is early labor to full dilation. And this is number 15 slide, by the way, on the PowerPoint, just in case you guys haven't seen. So stage 1 is early labor to full dilation. Stage 2 is pushing. Stage 3 is the delivery of the placenta. And stage 4 is the golden hour. That's when you definitely want to try to do skin to skin as much as possible. And, just kind of breastfeed if you can as well. Now, I have a little bit of a review. We only have a few minutes left of the class. I know that we talked about a lot, and I wish that we can talk about more as well, but I will be having part 2 next week as well. You can log into the Eventbrite and you can register from there. And like I said, you can also have consults with me as well. I do have the online, I'm going to put it on here too. Let me see. But I actually just created the Childbirth Masterclass online, and you can actually get 8 lessons for free. And then the rest of the lessons you can get yeah, there we go. I just put it on there. So it's actually in the comments. So keep in mind that after this video is over, I will be deleting and disabling comments for privacy reasons. So if you guys want to sign up for the class, you definitely want to click on it now, or at least like save it so that you have it. And you can also see it from my website as well, and I'll be emailing it. But this is great. It's literally a 1-month-long class, and it goes over everything from pregnancy, childbirth, postpartum, newborn care. I go over breastfeeding. I go over pumping. I go over bottle feeding, everything. And it's literally 1 month long. So it's very good. And I do offer consultations as well. So you can either email me or you can sign up on the consults tab. So like I mentioned before, we will be doing a giveaway in the end of this class for a free consultation. So before we start, what I'm going to do is I'm going to do a review with you guys just to review what you have learned, because I don't think that learning comes by only listening. I think that learning comes by discussion, by doing, and especially by applying what you have learned. So because of that, let's do a little review, and everybody who is active in the review will be eligible for the consultation. So to start off, let's talk about pregnancy. My first question about pregnancy is, what are some complications of preeclampsia? I feel like we talked about that a lot in our class. So I just want to see if you guys were listening. So you guys can comment on this section, the comment section, to see if you guys were listening. And I really hope you were, and I hope that you guys are learning a lot from this class. So we would ask, what are complications of preeclampsia? And remember, preeclampsia is high blood pressure. So that can be complications for mom, complications for baby. If you think about it, the blood vessels are more constricted, they're tighter, there's not as much blood flow going to the placenta. So that's how you might end up with a few complications. I know sometimes the comments take a little bit. And then a few complications of preeclampsia, and even if you comment later, that's fine. But a few complications is a small baby, that's number one, and also preterm delivery, because let's say your blood pressure gets too high, too fast, they might have to deliver you earlier. And then my other question is, what are some complications of gestational diabetes? So gestational diabetes, remember, is high blood sugar. So what are some complications of high blood sugar? Big baby, exactly. Sebastiani knows it, exactly. So a complication of gestational diabetes is having a big baby. Also, one very important thing is having a baby with low blood sugar. So you want to make sure that your baby is warm, that your baby's skin to skin, effectively feeding, so that your baby kind of has the best start possible. My next question is, at how many weeks is a baby considered early term? So we talked about between 35 and 37, the baby's pretty still premature, but yes, exactly. Natasha's correct. 37 weeks. So after 37 weeks, the baby is considered early term. And then at 39 weeks, the baby is considered fully term. So we're trying to get our babies to hopefully cook in the oven as much as possible. So we talked a little bit about childbirth as well, and labor and delivery. So who can tell me what are a few things that you want to happen in the golden hour? So that was stage 4, the golden hour. The golden hour is the first hour of life after the baby has been born. I mentioned two big things. Exactly. Rosa knows it, skin to skin. So we want to do skin to skin. And if you want to breastfeed, exactly, you want to hopefully breastfeed as well. So far we have Sebastiani, Natasha, and Rosa are all in for my giveaway so far. Now let's talk epidurals. What is a big side effect of epidurals? And remember I was mentioning that because of the side effects, that is why sometimes epidurals take a little bit longer to have, just because you have to wait for them to do certain things. But I mentioned a really big side effect, low blood pressure, exactly. So that's why they have to give you that. We have to give you that bolus. We have to give you that extra fluid to hopefully help you in that process. Now, I would like to open up for questions if you guys have any questions. And then if not, this is technically the end of the class, but I would be more than open to any questions that you guys have. And also, if you can tell me your favorite part of the class, or even if you learned something that you did not know before, I just love to hear what everybody's learning, what everybody took out of the class, and what you liked about the class more than anything. Because I know that there's a lot of options for you online right now. So I'm very excited that we got to meet each other. And I really hope that we can continue to connect on Mommy Did You Know? And you can also follow me. I have Facebook, I have YouTube, I have a little bit of everything, Instagram as well. And then, like I said, you can also take my class. I did put the link in the comments section, so make sure to try it out before you exit, because once you exit, the comments will be going away. But this class is great because at least you can have 8 days free, and then the rest, if you want to continue, they're there as well. But I just wanted to say it was very nice to meet you all, and I wish you all the best. And if you guys do have any questions, you can also email me. Went into detail with the complications as far as what to expect for earlier being induced. Yeah, of course. And then especially as a first-time mom, you have a lot of questions and you don't really know what to expect, especially because when you're a first-time mom, you don't really know how your body is going to react to things, or unless you work in maternity, you don't really know what's going to happen in the hospital. What are they going to do? Even something as similar, like as simple as how the epidural is given. Like, I don't know how many times people think that the needle stays in their back. I'm like, no, the needle is just there to penetrate the skin. And then once the catheter is in, they can retract the needle and take it out. And then I love to teach as well. So Rosa or Natasha or anybody, if you had any questions about anything, you can always schedule a consult. So let's do the giveaway. So we had a few people that were talking in, let me see, we had Sebastiana, Natasha, Rosa. So Sebastiana, okay, so we have, yeah. So all of you guys, let's see, Sebastiana, I keep saying it wrong. Sebastiani, Natasha, Rosa. So of you three, one of you guys will be winning. I'm thinking of a number 1 through 10. Whoever gets the number right will be winning a free consultation with me. And then I will tell you how to get it. So I'm thinking of a number 1 through 10. This is the easiest question I've had so far. So we have Rosa said 7, Natasha said 8, Sebastiani said 6. My answer was actually 7. So Rosa has won the free consultation with me. So congratulations, yay. And the rest of you guys can still have a consultation by going to the consults tab on mommydidyouknow.com. Yes, I'm very excited about it. So what you can do, Rosa, is sign up on mommydidyouknow.com and then go to consults. And then you can sign up, and then where it has like forms, consent forms and stuff, and where it says where were you referred from, you can just say live class winner, or won the live class, or whatever you want to say for that. But I remember your name, so I'll see that, and then you won't have to worry about paying or anything, because I'll just put it manually, so you'll be able to be just fine. So you can go to mommydidyouknow.com. consults. And then Rosa, you can just put winner of the live class for the referral, okay? And then whoever else wants to schedule a consult, you can also put, live class or whatever you want. So I know where you guys are from. It was very nice to meet you, and I wish you guys all the best. And like I said, you can always email me as well. Do anybody have additional questions before I close the video? Then if you guys did, you can let me know. You are very welcome, everybody. And I'm sorry, I'm still coughing a little bit. Hopefully I get better soon. It's been like this for a few weeks, but it's just lingering. All right, well, I wish that everybody has a wonderful day, and I do have more videos on the channel too, so make sure to subscribe and you can get more videos as well. I have a whole bunch of great stuff. All right, it was very nice to meet you all. I wish you all the best.